Good afternoon, everyone. Thank you for joining PHCA for today's webinar, Test Solutions for COVID-19, Current Challenges and Looking Forward to Mitigate Risk. I hope everyone is doing well and staying healthy during this ongoing challenge with COVID-19. We recognize the extraordinary work that you've been doing through this crisis, and we want to thank you for all that you're doing. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for PHCA members. For those attending outside of Pennsylvania, first, welcome. And secondly, your association staff will be in touch with you on how they will be handling your attendance. A survey will be launched at the close of the webinar. Your feedback is important to us and our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit your questions using your questions pane on the right hand of your screen, and our presenters will address them at the end of the presentation. I'll now turn the webinar over to Karen Gerwitz, who will introduce today's webinar and speakers.
Good afternoon, everyone. Thanks again for joining. Like Wendy said, I am Karen Gerwitz. I'm Senior Living Channel Manager for Eurofins. And we also will have talking first is Dr. Steve Kleiboeker. He's our Chief Scientific Officer for Eurofins Clinical Diagnostics. And then also Dr. Richard Higby, Vice President of our Eurofins Microbiology Division. So Eurofins is a world leader in the provision of clinical diagnostics, forensic, pharmaceutical, food, environmental, and agroscience laboratory testing. Our mission at Eurofins is testing for life, and we put our full energy and commitment towards supporting the fight against this pandemic. In the U.S., we have 10 lab locations that can conduct COVID-19 clinical testing and additional labs that can provide environmental monitoring for SARS-CoV-2. In the state of Pennsylvania alone, we have 2 labs in this testing space. Our clinical lab, formerly known as Lancaster Labs, and our environmental lab in Horsham. Eurofins is actually the 6th largest employer in the state of Pennsylvania. Eurofins offers the only long-term solution on the market today that provides the comprehensive testing strategies and practical implementation approaches critical to reducing the impact of COVID-19 on your facility. Dr. Steve Kleiboeker will now present on the clinical testing front.
Thank you, Karen. Yeah, so first I'll talk about antigen assays, and there are many different types of testing out there: antibody, antigen, PCR. I'll cover the antigen and the PCR and really just talk about some of the strengths and weaknesses and help you hopefully have a better understanding of how these tests can be used, or how they should be used, I should say, and then more importantly, how they can be used together. So first, antigen assays. The advantages of these types of tests is that they are low complexity and they can be performed quickly and oftentimes on site in non-laboratory type of locations. The results can be used to identify people shedding high levels of the virus, and thus these are the people that are most likely to be spreading the infection to others. However, as with most things in life, nothing's perfect and there are disadvantages. Mostly with antigen assays, we think the disadvantages are in the accuracy, especially the sensitivity. So the antigen assays often don't detect those that are just shedding a little bit of virus. They only detect those that are shedding moderate to strong amounts of virus, and weaker positives are often misdiagnosed as negative. So antigen assays are typically reliable for detecting negative people, but not always as reliable for detecting positive people. Next slide, please. The other type of assay that I'll talk about for a few minutes is the PCR assay or PCR test. And so many of you have probably heard about this. This is probably the most common test that you'll hear about at the various sites across the US. This is a high complexity test, and it really is the gold standard. It must be performed in a laboratory. Now, there are on-site PCR methods that some of you may have heard about, but generally these are not as sensitive and so have some of the same drawbacks as the antigen assay. As I said, the PCR method is the most accurate method. The disadvantage, however, is that it's relatively slow, mostly because of the transportation time and the batching time. So these typically get run in very large batches, several hundred samples at a time. So there's some delay there. But more importantly, they often have to be transported to a laboratory. And so the delay can be 24 hours or more. We at Eurofins have worked hard to drive that down to 18 hours or so, but again, it's, as you can think about the antigen assays, it's just not as rapid as those, and it's certainly typically not at a location where you might have gatherings of people. Next slide, please. There is a common thought today that we can combine the antigen and PCR assays and really use the advantages of both, and of course the disadvantages can be offset by the other type of testing. So when these are used in combination, you can have rapid on-site identification of high-level shedders by the antigen assay. Any of the samples that are negative would then go to a PCR-based testing for more definitive type testing, more sensitive testing, and this can provide an approach that's both powerful and fast. Here's an example of how this might use. If you can envision a gathering of individuals that requires close contact, the social distancing maybe wouldn't work as well, whether it's a work environment, conference, travel. The idea is that you could test all individuals at the gathering early on, ideally before they even had much contact with the antigen test. This would provide results quickly. As I said, as rapidly as 15 minutes. Now, just a little sidebar on the 15 minutes, that's per test, and these don't run in parallel very well. So if you have a lot of people, you would need to have a lot of antigen testing capabilities on site to get done quickly, or you could just work through the group in series. But regardless, they are rapid, they're low complexity, so they're on site. This would allow you to identify the strong positives, if there are any. Hopefully there are none, obviously. And perhaps they could be excluded, sent home, if you will, or just not allowed to join the group. You may want to retest to confirm these. But then any individuals that were negative by this initial screening test, the antigen testing, would then be tested by a PCR method. Again, this is the more sensitive test. The results would likely be available the next day. So they would have to go off-site and go to a laboratory environment for the completion of the testing. This would allow you to exclude all the positives, and then you could retest, if there were any positive, you could retest close contacts as they get into that potential transmission period 2 to 4 days later, up to 14 days actually. But this combined use of antigen and PCR methods is now being viewed as probably the next wave of how we can work together to get back to some of the ways of work and socializing and entertainment that we've had in the past. Next slide, please. So to switch gears a little bit, I'll talk about vaccines and how this impacts the future of the testing that we do at Eurofins, as well as others are doing out in the field. Next slide, please. So first of all, the good news, and probably maybe one of the more shining examples of science in the recent years, is that these vaccines that have been developed very rapidly are turning out to be both safe and very effective. And even with the variant strains that you've heard about on the news, the so-called UK variant or the South African variant, there's been a lot of rapid work done, and it's shown that while there is some drop-off in protection against, say, the South African variant, I should say drop-off in protective titers for the South African variant, it still seems like they are very effective. Just think of the recent J&J experience in the South African country, where they had very good efficacy in just a tad bit lower than what they had in the US. And the important thing is that these clinical trials that we've probably all read about, some of us in the newspaper, some of us have dug into the actual scientific publications, but these clinical trial results really do appear to be representative of our real world experiences. And so sometimes we do experiments in the lab, or we do a clinical trial, and you get a certain result, and then you get out into a more diverse population and you have less efficacy. But fortunately, that really hasn't proven to be the case for the SARS-CoV-2 vaccines. They've really performed as well in the real world as they did in the trials. What is interesting, though, is that these neutralizing titers, while they may be lower for some of these variants, they still do appear to be sufficient for control. Now, that's not to say that there is still, that we're out of the fight, that we've got everything figured out. Boosters, for example, maybe in 2021 or even in 2022, will likely be required, and these may include some of these variant strains. But this is not unusual. And so if you think about the flu vaccine, and those of you who follow that a little bit closely know that there's a discussion and sometimes even a change of the formulation every year for the flu vaccines, just based upon the prevalent strains. Now, there is some years where we don't change because the strains haven't changed, but this is a common occurrence in the world of vaccination, especially when you're talking about viral vaccines, because the strains do change over time, and so we have to maintain some flexibility. So while we have a great start with vaccines, we still have work to do, but I think the bottom line is the progress to date has been very encouraging. Next slide, please. So what is the impact of vaccinations on testing? Well, first of all, testing will still be required. As many of you have probably heard in the news, we're anticipating having enough vaccines to vaccinate the entire population of the US in the next few months. But having enough vaccines and getting that vaccine delivered into arms, so to speak, isn't really going to occur. For one thing, it doesn't include the pediatric population, and so that's a very important group. Even though they haven't suffered quite as much from COVID, they still are vulnerable. As I said, the vaccines are excellent but not perfect, and so laboratory testing and a couple of types of testing I'll talk about here, the neutralizing antibody testing and a T-cell immunity panel, can help us identify individuals that are perhaps not protected after vaccination, or even those whose immunity declines, or the medical term is wanes, sooner than expected. So a little bit of background there. Right now, we don't actually know how long these vaccines will last. There have been papers that have described 8 months, 6 months. It's still an unknown how long they'll last in the general population. And of course, we know based upon a typical vaccination type study that people will lose their immunity at different times. Not everybody is going to have immunity through, say, month 6, and then everybody loses immunity. So we think that these laboratory tests, neutralizing antibody testing and these T-cell assays, can certainly provide study data that will allow us to understand, okay, when do we need to revaccinate? It's going to depend upon the amount of virus circulating as well. So the assays, the testing that I talked about just before, both the antigen and the PCR type assays, will still be important, because we have to know, is the virus out there? Is it out there in all populations, or in just pockets of populations? And then for those that have been vaccinated, are they still protected, or will they need some sort of a booster at a certain period of time? So testing and vaccinations go hand in hand. It's really hard to have an effective program for vaccination without testing, and it's, of course, without vaccination, testing is not typically just going to control a pandemic. Just a little bit of background. There are a number of ways to measure immune response. So I talked about the two, and the one in the center and the one on the right there, the neutralizing antibody testing, and then the T-cell immunity. The one on the left is probably the one you've heard the most about, just the general antibody testing. And this looks for a couple of different types of antibodies. The IgG is the longer lasting, more robust response. The IgM is the more rapid, the recent response. These have proven to have some reasonable utility, but they're best used on a population basis. Has this population been exposed? They're really not that useful for diagnostic purposes, although in some cases they do provide additional information that can be very important. But that center column there, the neutralizing antibody, this is where really the protection occurs with antibodies. Can it actually bind to the virus and prevent it from entering the cells of our body? And so that's a more direct measure of protection. And then the cellular immunity, the T-cell immunity on the right, there's a couple of subclasses of cells that are very important for protection. We call them CD4 and CD8 in the laboratory. And knowing if an individual has cells, T cells in this case, that recognize SARS-CoV-2 is key to understanding how well protected they are. And eventually, for the neutralizing antibody and the T cell test, we will have quantitative levels. We don't have those yet. Still, it's a work in progress by a number of labs, including those at Eurofins. But we will have numbers, quantitative measures that say, okay, well, if you have this amount of neutralizing antibody, your protection is excellent. 90+%, for example. So a lot of work to do, but the basis of measuring the immune response is shown here on this slide. Next slide, please. So a little bit more about neutralizing antibody. These are developed in two ways, either after people have an infection or after vaccination. And so that's the good news. The antibodies themselves, as I said, that's really the key, is that they do prevent the pathogen from entering the cells. And so that's where the protection, the biological effect occurs. And then I just mentioned this neutralizing antibody testing that goes after what many of you have heard about is the spike protein. And the spike protein, by the way, is the key piece of the vaccines that we're making. It's from the virus. It's part of the virus coat, if you will, and it is what is required for virus entering the cells. And of course, if you can make an antibody to that, you'll have protection. And then, as I said, we're still trying to understand a lot of things about neutralizing antibodies. For example, how long do they last, and what is a level that confers a quantitative number that confers protective immunity? So a lot here still to learn. It's been a busy year, and unfortunately, we still don't know everything yet about the various results and how we can most effectively interpret them. Next slide, please. So the potential uses of this, I think I probably mentioned this a little bit, but I'll just emphasize the important points. They could be used to predict who is protected from reinfection. And so I think those of you who have listened to the news have probably heard about a small group of patients who actually get reinfected with a second different viral strain, perhaps, or potentially even the same strain. But the theory or the hypothesis at this point is that those individuals either never had or lost their neutralizing antibody early, and that allowed them to be reinfected. So again, I think you can easily make the next step here. That's why knowing what a neutralizing, or knowing if an individual has a neutralizing titer, can be important. Clearly, those without neutralizing titers, even if they were vaccinated, even if they had a prior infection, they're going to be far more susceptible to reinfection or a second infection than somebody who still has a robust neutralizing response. And then, of course, evaluating the vaccine efficacy. I think I belabored that point a little bit before, is that we can understand how long the vaccines last, when they're likely to lose an individual is likely to lose their protection from a vaccine by testing a patient with a neutralizing antibody assay. Next slide, please. So a little bit about T-cell immunity, just diving into the details. It uses a specialized lab method called flow cytometry. And we can actually look at the number or the percentage of T cells that are responding to SARS-CoV-2 antigens or proteins. Antigens are what the immune system recognizes and develops a response to. And so it can evaluate this for these two key classes. Here, the potential uses are not that different really from the neutralizing antibody. They're complementary. For those of you who have studied the immune system, you know there's two arms to the immune system, the cellular immunity and then the humoral or the antibody immunity. So neutralizing antibody, obviously looking at humoral, cellular is the T-cell assay. We're looking at both arms, but it can be used to assess the immune status, say before vaccine administration. many of you have heard that patients who have had COVID, they're going ahead and getting a vaccination, but there's even now some talk about only giving those individuals one vaccination dose. I think they'll probably stick with the 2 doses, especially since it looks like our supply in the coming months will be good. And then, of course, knowing if a patient has this T-cell response, this may be the reason why these patients are getting infected, or I should say reinfected, after either a previous illness or a vaccination. We don't really know. Is neutralizing antibody sufficient? Does it require both T-cells and neutralizing antibody, or is it just T-cells? And so while the antibody testing is really good to understand populations, really knowing the specific antibodies and then also the T-cell story is key to getting the full picture in these clinical and vaccination scenarios. So the impact of variants. Many of you have heard, we talked about it just briefly a minute ago about these various variants, but specifically, what's the impact of these variants on testing? Well, I told you that PCR is really the gold standard for testing, but one key detail is that PCR assays have to have a near perfect match between the design of the assay and then the strain that we're targeting. So the UK strain, that has some differences in the genome of the virus relative to the standard strains that we dealt with in the first several months of the pandemic. It has changes in the genome, and that is what the PCR assays target. So if the PCR assay is targeting a region of the genome that has changed in something like a UK variant, you'll have what we call in the lab a false negative. It will be negative on the lab report, but it's actually, the virus is actually there. So with the PCR testing especially, all these new variants have made it absolutely necessary that we evaluate our assays on a regular basis, even as new strains are identified, even weekly or monthly, to maintain accuracy. Now, most of the assays these days, and certainly the assays designed and used by Eurofins, actually have redundancy, where we're looking at, first of all, we look at regions of the virus that don't change, but just in case we aren't perfect in predicting those, we'll combine a couple of different assays so that if one assay has a weakness in a certain strain, it's covered, if you will, fully covered by a second assay. So you get one result as a physician or as a consumer, you'll get one result from the lab, but going on behind the screen, if you will, there's multiple assays at play. And then of course we're monitoring those as all these variants come out and are reported widely, both in the news and also in the scientific circles. We're monitoring the assays to ensure that we still have good accuracy and that we're not subjecting the patients to potentially dangerous false negative results. So it's a lot of ongoing work, but 100% worth the effort and absolutely required for accuracy. Next slide.
Okay, thank you, Dr. Kleiboeker. I will carry on with Dr. Richard Higby's slides, as he had something else come up in last minute and was not able to attend. So we'll talk about the surveillance and screening testing for SARS-CoV-2. What this is ongoing systematic activities which are essential for planning, implementing, and evaluating public health practice. So the screening is intended to identify infected individuals without or prior to development of symptoms who may be contagious, so you can take more proactive approaches. So comparing surveillance versus screening, surveillance does not require a CLIA certificate. And most facilities do have a CLIA waiver, CLIA certificate, but that has been a struggle in other areas. Maybe assisted living doesn't, or senior living doesn't, where screening, on the other hand, requires this. So it just makes it a little bit easier for surveillance testing to take place. Same thing with FDA emergency usage authorization for surveillance in kind of a sentinel program. It's not required, but for screening and clinical testing, it is. And on the surveillance side, it doesn't allow for delivery of patient-specific results. So we'll talk about pooled testing is like a cost savings measure, where screening is individual and it will allow for individual patient results. So under surveillance, these results should not be reported to a health department, where screening, it is required. So we want to detect, then determine, and then disinfect. So what I'm talking about here is with surveillance testing, it is a first step in early detection. So one example is worn masks. You can require or give it is an option for staff or residents to wear disposable masks. You can collect those masks, label them with the wearer's name, send them to the lab, and then we can run them as a pool. So having results by the next day, if there's a positive within that pool, keep in mind it's not screening, so you will not know specifically who has it, who is shedding the virus, but what you will know is somebody within that pool and in your population, so you can dig a little bit deeper and then move into screening testing. So this is just helpful because it's more cost effective. I do realize that right now there are regulations that are requiring the testing, either at a minimum staff once a month or sometimes up to twice a week, depending on the county positivity rate. But if you're not in that requirement or moving down the road with requirements hopefully loosening a bit, this would be a great option for you to consider. So if you did have positives, you'd want to clean and disinfect the employee workspaces. You'd want to collect surface swabs for verification. And again, you send them overnight to get the quickest result possible. And then you will receive results the next day. So here's kind of, over this period of time, which is, like no other, we have developed sentinel methods in advance of need throughout our 48,000 scientists and across 800 laboratories. So the outbreak started in December 19th, in December of 2019. At that point, most of us really weren't thinking it was going to happen to us. In March, it was actually considered a pandemic. And by April, we had rolled out surface testing. And by July, we had partnered with a lot of our food manufacturing clients to help keep their essential workplaces open in producing the food that we need on our tables. In August, we introduced wastewater testing into our program. In October, air testing. In November, worn mask testing, and then this year, pooled saliva testing. Again, this is all a sentinel testing program or surveillance, either in combination with the current screening their facilities are doing as required, or maybe moving forward when the requirements loosen up a bit, how to continue staying safe. So again, for the kind of looking from an individual, you want your nasal swabs, your nasal pharyngeal swabs. Then you might want to consider mask testing, and that would be in a pool of up to 10 masks per pool. A little bit larger than that is a pooled saliva test, which can be up to 20 people. Now for air monitoring, what this will tell you is it's a cartridge you can determine is coded present in the airspace. We know that it travels, it's airborne, it's in the air, but also what kind of HVAC or air filtration system do you have, and how is that, how efficient is that with the air testing? Do you need to change your filters? Do you need to change your system? Do you have groups that are segregated if you have a wing of COVID positives or suspects versus a wing that is just tested negative, are they safely being kept apart? And then wastewater is another one, which is very interesting. Studies have shown that up to 7 days prior to some individual showing a positive COVID-19 diagnosis through a nasal or nasopharyngeal swab, it will show up in their wastewater testing. So again, with wastewater, you will know that it's in your population or in your group up to a week prior to someone shedding the virus. And it's very sensitive. 1 in 1,000 people could be infected, and the studies have shown that it will show up positive in the wastewater testing. Okay. So now, what we all want most is safer socializing for our more vulnerable population. We need to keep our residents safe, but they need to have a quality of life they deserve. With the vaccine rollout and hopefully some regulations changing a little bit because of this, you want them to be visiting with their loved ones and their family, and there are ways to do this safely with a good program in place if and when it is allowed by regulation. So safety programs consisting of a combination of measures should be in place to reduce risk. A facility can require negative PCR, the gold standard that Dr. Kleiboeker referred to, test results within a short window prior to the visit. There can be at-home self-collection test kits available to order that are sent directly to the potential visitor's home, with results being available within 48 hours. Additionally, antigen testing can be conducted on-site at the facility for potential visitors before they're allowed into the facility, either solo or in addition to the at-home PCR negative test result. Of course, on-site precautions should include visiting outdoors whenever possible, hand washing, social distancing, and double masks. So double mask is the disposable surgical mask is the first layer, and then the second being a fabric washable reusable mask. And the mask should always be tightly fitting around the nose and cover the nose and mouth. So we have spring right around the corner. To resume any kind of picnic event, outside gathering, you'll want to have a protocol in place for this as well. Again, outdoors is always better than indoors. One thing you might want to consider is contact tracing devices. These are small, they're about the size of a pager. For those of you who are younger and might not know what a pager is, smaller than a mobile phone. If you picture that, just worn on person, either in, clipped on a belt or your top or in a pocket. And they are programmed to represent the individual of the person that is wearing it. And they're very nice in the event that someone after an event does exhibit symptoms of COVID-19 or test positive after the event. And that if this happens, these tracers collect data every time an individual comes within 6 feet of another individual wearing a device, and it will record the actual amount of time spent within that 6 feet distance. And reviewing the data, you can make a determination based on who was close to that person, who they were close to, and the amount of time that they spent within that social distance kind of circle. So pictured here are just ideas to consider for getting back to normal or on-site gatherings. Okay. And that is all I have. So if you'd like further information, have any questions, please, you can route those through myself, Karen Gerwitz. My contact information is up here. As Wendy said, the presentation will be available, and this will be included later as well. So thank you.
Great. Thank you so much for this information today. We are open for questions at this time. And yes, we will be sending out the PowerPoint presentation in a follow-up likely tomorrow. So any questions, go ahead and type them in the questions pane on the right hand of your screen. We still have some time left in our webinar time here today. So any questions? We'll just give that a couple minutes here, wait for them to come in. So last year at this time, it's hard to believe that, you know, we're having this discussion a year later. We never saw it coming. Wow, you must have done such a good job at presenting all of the information. There aren't any questions. Sometimes this is a quiet group. All right, we'll give it another minute. Again, we have here at PHCA, we have other upcoming webinars. Next week, we have an advocacy webinar on March 11th. Our own President and CEO, Zach Schamberg, and our new Government Relations Director, Tim Ward, will be presenting on it next week. And then we have our Quality Symposium coming up starting on March 18th. And we also have webinars planned into April, May, and we're looking at some topics for early June at this point. So if you do have any topics that you would like to see us present, please type those up in your survey and we'll add them to our list as we're looking to schedule for the rest of the year. All right, I'm not seeing any questions. So again, Karen's information is there. I will send that out in the follow-up email. Just a reminder to stay on to complete the survey. Today's webinar has been recorded and will be made available on the PHCA website. So if you know anyone who can benefit from that, please send them to our website. That will likely, again, be up on the website tomorrow. And I just want to take a moment to thank our speakers again for today's presentation, and just wish everyone a good remainder to the rest of your day and week, and stay well.
Thank you.
Thanks, Wendy.